Let us build a healthier, more resilient, and prosperous Africa where no one is left behind. I thank you.
And I think that's what has been lacking. The knowledge of non-communicable diseases
Good
and
morning.
communicable diseases is well known by all of us in this room.
IT.
It is indeed a great honor and privilege to welcome you to the inaugural national.
Good morning once again, ladies and gentlemen. Thank you for keeping time. And like we had mentioned, we are starting so that we can be able to manage the program that we have for today. But before we start, as it is our tradition, I'm going to call upon Joanita Narwanga. Joanita Narwanga, please step forward and you bless our day with a word of prayer so that we are able to start.
Good morning, ladies and gentlemen. Let us all stand up in honor of God's name. We humble ourselves and pray. Heavenly Father, we thank you for this morning. We thank you that you have brought us here today. We dedicate this day into your hands and the entire program. We dedicate the instruments and the people who are going to share their presentations today. May the day be fruitful, Lord. And for those that are still on their way, we pray that you grant them journey mercies. And for the rest of the conference days that we have ahead of us, we put them in your hands. In Jesus' name we pray. Amen.
Thank you, Joanita. You can give her a hand of clap. All right, thank you. In the meantime, the IT team, please load the presentation for the rapporteur. Ladies and gentlemen, you're most welcome to our day 2 of the main conference. Those of you who are joining us today, this is day 2 of the main conference, but at the same time, it is day 4 of the entire week where we had 2 days of the pre-conference. We welcome you for today's session. Today's plenary session is going to take us up to break time, and after that, we shall have our breakout sessions. But before that, once again, I'm requested to remind each and every one of you that please don't take your seat before you complete your registration at the rapporteur's table outside, because your registration at the same time comes with your meals coupon. We had a number of sessions yesterday running, but to just give us a heads up on what transpired yesterday and to continue the discussion that we shall be having, I'll call upon Mukama to step forward and within 5 minutes, just give us a highlight of what transpired yesterday to some of our colleagues that have joined now through the issues that we were able to capture. And as he does that, the people supposed to be in the next session and the session chair will be preparing, because I'll be calling you after 5 minutes. Mukama, you're welcome.
Thank you very much, MC. Good morning, ladies and gentlemen. On behalf of the rapporteur team, I'll be sharing with you what transpired yesterday briefly, so that it can usher us into day 2 of this conference. So again, how do we define our day 3 or day 1 of the conference? We're defining our day as a unified action to achieve integration through innovation, based on the discussions that happened yesterday. That's how we defined our day. Again, the outline, we shall look at the objectives, the key themes covered, the highlights and issues discussed. What are some of the practice recommendations? Some quotes, what areas of improvement, and then the suggested follow-ups. So the objectives here, we had a grand launch of a conference yesterday. We had the dignitaries here. Again, a review of Uganda's status and strategic priorities for both communicable and non-communicable diseases, showcasing government and partner commitments to integrated multi-sectoral health action, and exploring innovations, data, and policies driving progress towards disease elimination by 2030. So the key themes that were covered, again, is integration of communicable and non-communicable diseases programs, multi-sectoral collaboration in prevention and health promotion, health system resilience and workforce readiness. Yeah. Sorry about the interruption. We are looking at the themes that were covered in the day one of the conference, and we had said we had health system resilience and workforce readiness. We also looked at the digital health, data use and innovation in surveillance, lifestyle risk factors such as alcohol, diet, inactivity, and mental health. And then the last theme was quality of care and patient-centered approaches. We had highlights for the conference, and I will pick out a few. I will start with the one in yellow, where we had the minister reaffirm prevention, integration, and innovation, celebrating progress, immunization, and physical activity, while warning of rising obesity and inequities. In gray, we had a highlight from the permanent secretary, where she launched the conference urging unified evidence-based action and behavior research to improve community uptake of services. And then I will go to blue. Dr. Stavia, the commissioner, said we need to set ambitious overlapping representations, and then the need for clearer follow-up mechanisms on the resolutions. The three takeaways: one is Uganda is pursuing unified action against communicable and non-communicable diseases through integrated service delivery and multi-sectoral collaboration, but also the 2023 data that showed progress. Yes. Yes. The second takeaway is the data that shows progress in tobacco reduction, but alarming increase in alcohol use, obesity, and sedentary lifestyles that require stronger prevention measures. And then the last takeaway is leadership commitment from the Ministry of Health, the academia, and partners in driving a renewed focus on behavior change, prevention, and quality of care. Thank you very much. This has been done on behalf of the rapporteur team. May God bless you and have a blessed day.
Thank you, Mukama, for that presentation. You can give him another round of applause. In case there are key issues you feel that were also mentioned and captured, the Secretariat remains open. You can please find a way of noting them down. And remember that at the end of these days, we must put all these into a proper action plan.
Progress.
So kindly note, in case they didn't capture anything of importance, please bring it up. The session chairs who are in the breakout rooms, we also request that if there could be key particular issues of discussion that were being discussed and noted, you can also ensure that we all have them captured in the report. We apologize for the power shutdown, but we hope we shall stabilize. And at this juncture, allow me to welcome our chair for the next session. Our next session is going to be focusing on the health system resilience amidst shifting funding landscape. And we are trying to see what African countries should do. And for this session, we shall have a panel discussion and a keynote speaker. And it's my pleasure to welcome Dr. Elizabeth Ekirapa, the Associate Professor from Makerere University School of Public Health, to come and guide us through this session. Professor, you'll have up to 10:30 to take us through this session. Thank you. You can give her a clap as she comes to take us through, and welcome her.
Thank you. Good morning, everyone. You've already been welcomed, but allow me to welcome you again. I want to welcome all of you to this second day of this conference. I also want to acknowledge and particularly welcome commissioners from the Ministry of Health, Dr. Stavia Turiahabwe, other assistant commissioners who are with us. I also want to take this opportunity to welcome faculty from the College of Health Sciences, deans, professors, senior lecturers, and all of you in your different portfolio. I also want to welcome partners who are with us, country directors, program officers. You are welcome. I also welcome our development partners who are with us in this session. Like you have already heard, we are going to be looking at health systems resilience. And when we talk about resilience, we are talking about having a health system that has the ability to prepare for, to respond to recover from, and also to adapt from shocks. And those shocks are different. They may be pandemics, they may be natural disasters, there may be different types of conflicts. At the moment, we are certainly dealing with the financial shock. And so our discussion is going to focus around how do we continue to provide the essential services that we need to provide amidst these kind of shocks. Health systems resilience is particularly important for several reasons, so that we can protect population health while we have these shocks, so that we can minimize the disruptions that we can experience during COVID. We were all able to experience those disruptions. Even in this particular meeting, every minute or so when the power goes off, I hear everybody sighing. So when we talk about resilience, there's so many different areas where we have to be resilient. It's also important so that we can ensure economic and social stability, and so that we can reduce the inequalities that may become more pronounced when we have those kind of shocks. And to help us launch into this topic, we have none other than Professor David Serwada. And Professor Serwada really needs no introduction. However, allow me to say a few things about him, but I certainly will not do a full introduction, because if I did, it would turn into a mini keynote address. So he was elected Fellow of the National Academy of Medicine in 2011. He is the founder of the Rakai Health Science Program, and as we are aware, he was the first investigator to identify what was in those days referred to as the slim disease. Those of you who are a lot younger than the rest of us probably do not know what I'm talking about when I talk about the slim disease. But in Uganda, sometimes people say, if you know, you know. So if you know about slim disease, then you are one of us in that respect. So he was one of the investigators who discovered that, and he has been at the helm of doing research looking at transmission and also prevention of HIV. He has been awarded numerous local and international awards. He was elected together with 36 others among the world's most accomplished scientists living in or focused on the developing world by the World Academy of Sciences. So Professor Serwada, you have done us proud, I must say. It's always great to see a fellow person from Africa recognized. It's even more exciting when that person is a Ugandan. So we really appreciate that. And his support and his experience stretches to several boards where he serves as chair and also as a member. Like I said, I could go on and on, but today that is not the purpose. The purpose for our having Professor Serwada here this morning is for him to introduce this topic and share his thoughts about what African countries can do to ensure that they have resilient health systems. Professor Serwada, it is my pleasure to invite you to share with us. Join me in welcoming Professor Serwada.
Thank you very much, Dr. Kalapa, for that very generous welcome. I was wondering whom he was presenting, but thank you. I need to, my slides. Is it me to start it off? Sorry? Yes? Oh, Kirapa, do you know how to do this? I need some assistance with this. Sorry. How do you start?
Just here. Place the signals from the other day.
Uh-huh.
So you just press the same.
And that's how I press to go forward?
Yes.
But we are not doing that, right? It's not coming. Oh, it's on.
Yeah, it's on.
Oh, so forward is just forward.
Bring one?
Yeah.
All right.
Okay. Sorry about that. Um, so, um, my topic is really to talk about resilience in the midst of global funding cuts. So, the official development aid assistance has projected that we shall have a 9 to 17% cut in 2025. To be sure, global funding for health has really been reducing for a variety of reasons, even before 2024, if you can see that in this curve. You notice that at around 2021, global funding for health has started to come down. And there are several reasons for this. One is that the global COVID pandemic outstretched a lot of funding from our usual donors for aid, but also there has been a shift in priorities in our usual donors or countries that are donating, mainly to really spend more in defense, mitigate migration, but also there's been a shifting priority. When I was preparing for this presentation, I was surprised. You see, health funding has been going up for quite some time and it's coming down. But a shifting in priorities when you look at climate change or climate or humanitarian crisis funding, it is really shooting up. It's really going out. So there's a bit of change in prioritization in terms of what people are funding. So in effect, funding has gone down quite substantially. Also, at the same time, African countries faced an increasing domestic debt and shrinking physical space, and I'll illustrate that. So all this is going to have a risk on health service continuity and health systems. Now, let's talk about the scale of the challenge. When you talk about Africa, about 25 countries are vulnerable to US global aid cuts. And ODA, which I talked about, per capita on sub-Saharan Africa fell from 50 to 23%. Now, when you look at the countries, government spending on health in low-income countries dropped from 13 to 10 USID per capita. And it surprised me that when you look at all public health funding in Uganda, public health funding, 95% of it was heavily lifted by US government funding. We are talking about the USID, the CDC, and NIH funding, which is a huge amount of money. The impact is all there to see, from programmatic to actually health systems, which we are going to talk about. The potential impact is quite high. Now, Elizabeth talked about resilience. She defined resilience. But I think what I'm going to add on here is that resilience is not only coping, but I think we should emerge out stronger. At the end of it, we should be stronger in terms of meeting our challenges, not just maintaining the status quo, i.e. loss of deliveries, but also turn out having better deliveries moving forward. Africa, of course, has about 26% of the world disease burden, but and also about 16% of the world population. But our spending on health is one of the lowest per capita. That gives us how vulnerable we are to reduced funding. However, this is going to be the linchpin of my presentation. And I like this quote from Afro-Africa, WHO. So, as global AIDS contracts in Africa, resilience will depend not how much money we receive, but on how wisely we invest the money it controls. And that's going to be the linchpin of my presentation. I'm now assuming no more money. We are dealing with the money we have. And I think for a long time, we think this is something that should have happened, but now must happen. So what I'm going to say, to be sure, we have been knowing for some time that funding in health has been coming down, as I pointed out, for a variety of reasons. And there have been many meetings. I mean, for the last 4 or 5 years, the meetings we have been attending have all talked about resilience, sustainability. Resilience, sustainability. How do we actually cope with reduced funding? And a lot of what I'm going to say has already been beaten to death. I mean, most of it has been known. But I'll be looking forward to our panel after my presentation. What can we practically do? We have talked a lot of what I'm going to say, but what can we do, or what is it disenabling us to do what we know? So there are about 6 points in terms of pillars of action to enable us to be more resilient. And the first pillar, which has always been talked about, to protect primary health care programs. Each country has to define, out of a proposed packet of primary health care, what it needs to really protect. And then the second point, integration. I think I can see from yesterday's presentation, integration was a very important point. Integrate vertical programs into primary health care. We are talking about integrating all programs that have been vertical into primary health care. Now, an example is going to be Uganda's district service, that compact. That basically assures what the government can do locally, regionally, and at the district level, and how we can minimize continuity of services during. That's a very good example for maintaining resilience. Domestic financing. I think we have a panel, one of our panelists is from the Ministry of Finance, but domestic funding needs to be now levied very heavily to be able to look at health. There have been several innovations throughout Africa on how to use or leverage domestic funding for improving health services or funding. I think the one that I saw in my review was Ghana. Ghana's VAT levy has a specific portion for health, which has been able to raise a substantial amount of money. Zimbabwe, now South Africa is experimenting with this. But it's very important to note that most of the countries have not been able to do this. Maybe this is something, why aren't we able to do that? Maybe I would like to hear more from the Ministry of Finance. What are the impediments for this? But the most important thing to note is where we are starting from. When you look at the Abuja Declaration, I'm surprised only 3 to 4 countries have been able to meet it in the last 24 years. The Abuja Declaration was in 2001, but only 3 countries. I put 4 because some are go in and out. One year they meet it, another year they don't, but only 4 countries have been able to have 15% of their budget allocated to health. Now, when you look at Uganda, when I was asked to give this, I asked my assistant to give me what has been Uganda's allocation to health sector over the last, say, 4 or 5 years. You will notice that actually between 2021 to 2024, the percentage allocation to the health sector has been dropping to 4.1 from 7.5. Then it suddenly went up to 8.4. However, that is still, when you look at the total annual budget has always been going up. If you notice, it's moved out from like 45 trillion to almost 70. But the percentage to health has not been commensurate to the increase of the annual budget. In actual real terms, the budget allocated to health has actually been going down. So we are really not adapting there or increasing. We have never ever been anywhere near the 15% for our Abuja Declaration. So what hope is there for us to be able to meet our home or internal financing? I would very much love to hear the various panelists discussing this in our presentations. Spending better before spending more. We have talked a lot about this. We have talked about cost effectiveness interventions. We have talked about pooled procurement. Pooled procurement, regional pooled procurement is now a very big thing, a very important item. We saw it in action during the COVID vaccine procurement under the auspices of African Union. It actually served us very well in procuring vaccines, COVID vaccine at the time. This is something many people are talking about, is one way to have economies of scale and be able. It worked for COVID. I'm not yet able to get any other example where this is happening. However, there's a lot of talk and lots of meetings to have pooled procurement. Because pooled procurement has been how the donors have been able to get us all kinds of vaccines or medication at a very low price. Global Fund, Clinton Foundation, they do huge procurement for various countries. But can we do it ourselves? We need a lot of strong leadership to be able to do that. The other thing has been reforming purchasing and incentives for health delivery. We have talked a lot about capitation, that is budgeting for a specific, a specific amount for a particular individual of a period of time. All this has not been very much done in Africa, diagnosis-related grouping, which is basically, but South Africa does, in some areas does this, which is basically putting a cost to a particular procedure and it pays per procedure, or diagnosis, sorry. And what has been commonly done or experimented with, even in Uganda, has been performance-based payments. Rwanda has been very successful in scaling up performance-based payments, and it has actually improved its service delivery. Uganda has experimented to some extent to this. I'm not too sure why we have never really scaled it up, but this is something that we really need to revisit and think in terms of the way we are providing services. Workforce and supply chain. This is extremely very important. You know, what is surprising is that Uganda is about to overproduce health workforce. However, we are not meeting the challenge of absorbing the workforce. But many people would argue that the community health worker has been extremely very important, especially if he is able to task shift in impacting the community health. down in the rural areas. And of course, many of us who have been in the HIV field, we talk a lot about community-based organizations as a way of sustaining, particularly maintaining. You see, to sustain and maintain diseases, particularly chronic diseases, it will require a little bit of a different mode of health worker as opposed to treating malaria. One comes in the hospital, health center, you treat him, he goes, you don't see him until he has another bout. But cases like HIV, malaria, TB, or diabetes, we will need a real big community push or community involvement in maintaining people in treatment. So those work first and being able to be more creative in how we develop and mobilize our workforce is going to be extremely very important in terms of maintaining resilience. Now, digital systems and innovation. I think Rhoda, from what I can see, Professor Rhoda Wanyenze talked about data. I think data is going to be extremely very important in making our system more resilient. We can prioritize, we can focus, we can evaluate what is working, what's not working. We can be able to shift our priorities. That is going to be extremely very important in terms of being much more resilient. We can foretell what is coming. So we really need, data is going to be extremely very, very important in terms of making us much more, know exactly where we are and where we would like to go and anticipate what might be needed moving forward. A lot has been talked about local manufacturing and procurement in the African region. It's so amazing that given the large population, given the huge disease burden, Africa produces very little of its own, of what it needs in terms of consumables, right? Ranging from drugs to other medical supply. And indeed, during COVID, this came up to the forefront, that we really need to produce, to how to be able to regionally be able to manufacture what we need. And I think a lot of effort is now being made in terms of how to be able to produce our manufacturing here. There are 3 countries that have really pushed this. We think in the southern region, South Africa is going to spearhead. They are trying to put up a lot of, with collaboration with companies in India, local manufacturing of a lot of drugs, particularly in the HIV/AIDS area. But in West Africa, Nigeria has really been able to push up in terms of trying to do local production. I think this is going to make us much more resilient, especially in scarcities of supply when there's a huge demand of supply. I think COVID woke us up in terms of local manufacturing and being able to do procure locally. I think that's going to be extremely very, very, very important. Of course, all this will need leadership. Critical leadership is needed at all levels, right from the top, right from the ministries, down to the districts, to actually prioritize, implement what we have been able to decide to do. I think that's very important. But the other thing that has been found to be very important and very helpful is accountability and transparency of procurement. That's our linchpin. And that's where most of the corruption, most of the wastage comes in. But for many years, we have talked of one plan, one monitoring and evaluation system, and one procurement system. Instead of every person, every organization, everyone procuring for themselves. That's why we get scales. But that will require leadership to be able to get us together. And I think many of us have had the example of Rwanda, where this has been able to be done and enforced, and how useful and effective it has been to be able to have one plan, one monitoring evaluation. And we have talked about this for a very long time. All this is not new, but why can't we enforce it? Why can't we implement it? I think with our own resources we have, I think this is one of the biggest challenge I would like to hear moving forward. Now, as I close, I think it is the how and the what that's going to be very important in our deliberation here. What I've said is, it's been talked about a lot. A lot has been talked about on the issues. But how can African countries protect essential health services from external funding decline? What practical steps can government take to mobilize and manage domestic health financing? We know that domestic health financing is going to be very important, but what practical steps can we actually do? How can we strengthen financial governance accountability? We've tried, but what more needs to be done? How can African countries strengthen regional and corrective bargaining power? That is regionalization, either in purchasing, in manufacturing. How can we do that? So in summary, I think in my presentation, it's a call for action. I think a lot is known of what we can do to be able to help ourselves to be more resilient. A lot has been discussed about this, experimented with in the past. But the most important thing is, what are the factors that either enable us or disable us to be able to implement what we know? And I think that is where the most important part of the discussion in this morning panel, in my opinion, should focus, because I think we more or less know what we really need to do in order to be a little bit more resilient. And remember, resilience is a process. As my presentation has pointed out, a lot of factors have to be in play. A lot of things have to be, working in tandem to be able to have a useful product. How can we be able to tackle that? And I look forward for the discussion this morning on how we can be more resilient and actually end up being much, much more stronger moving forward. And thank you very much for listening to me. And thank you very much for inviting me to give this presentation. Thank you. Do I sit here? Okay.
Thank you so much, Professor Seroda. You've got all of us thinking about the how and the what and what we need to do. And you've posed a number of challenging questions talking about the workforce. Are we training a workforce that will be able to provide the services that we need? Are we analyzing the data that we are generating? I think in our structure, we have one biostatistician at the district office and records officers who do not have probably the capacity they require to analyze the tons of data that we require. How can we strengthen that? How are we promoting accountability? And several other hows. And you posed the question about the how and the what. And so I'd like us to delve into the issue of the how and the what. And we are going to invite our panelists. As we are all aware, this conference is looking at communicable and non-communicable diseases. We are told it's not good to sit for too long. I'll ask you to stand as we invite our panelists. We are in an election period. Let's imagine they are members of parliament already elected. So we are going to clap for them as they come to the podium. Ladies and gentlemen, allow me to begin certainly with a lady. Allow me to invite Dr. Christine Musanu. Dr. Christine is from the World Health Organization. She's the team lead for communicable diseases and non-communicable diseases in Uganda. Dr. Christine, you're welcome. Let's invite her with a clap. Please do take your seats. Allow me to invite Dr. Edward Bitarakwate. Dr. Edward is the country director for the Elizabeth Glaser Pediatrics Foundation in Uganda. Dr. Edward, you're welcome. Your claps are very feeble. Thank you, ladies and gentlemen. Let's invite Dr. Nelson Musova. Dr. Nelson Musova is the Director General, Uganda AIDS Commission. Dr. Nelson, you're welcome. Allow me to invite Dr. Emmanuel Batibwa. He's the Executive Director, Mubende Regional Referral Hospital. Dr. Emmanuel, you're welcome. I have two other panelists, Dr. Richard Kavanda. I don't know if you have arrived. If you have, please do join us. When he comes, he will join us. It appears he is not yet here. Mr. Johnson Tumesigenzi from the Ministry of Finance. I don't know if you have arrived as well. Okay, those two panelists will be joining us. Thank you, ladies and gentlemen, for standing up. Do take your seats again as we continue delving into the how and the what. Okay, thank you, thank you. Dr. Stavia is going to represent Dr. Richard Kavanda. So, ladies and gentlemen, let's invite Dr. Stavia. Okay, so ladies and gentlemen, our panelists, welcome. Thank you for being with us. If you have questions for Professor Serwada, we shall be delving into that session at the end of this brief session. So I'd like to request the panelists to just share with us a few of their thoughts. And Dr. Stavia, I'm going to begin with you. Because Ministry of Health is in charge, Ministry of Health is in the driving seat, and you have been in that driving seat, leading the discussion about integration. So would like to understand, how does Ministry of Health define health systems resilience? How do you define that? How are you operationalizing that? What are the main things that the ministry is focusing on? If you could just take 5 minutes to tell us a few things that the ministry is focusing on.
Thank you, moderator. I saw Kavanda was supposed to talk about Ministry of Health Innovations, but I think it's in line with that. So what are the system things that the ministry is focusing on? Number one, we are redirecting our focus to preventive and health promotion efforts. You must all have heard about the introduction of the community health extension workers who are going to be at the parish level. This is in addition to the village health team at village level. This healthcare workforce at this level will help us in promoting in disease prevention, but also in promoting access to care, early diagnosis, and treatment services for the people who require communicable and non-communicable disease services. We are also promoting digitization of the health system, and this key reform is going to help us strengthen our data systems, be able to generate the evidence that we need to target our interventions, but also it is going to cut off a huge cost in printing of the tools that we have been using. Other than digitizing with the integration agenda, the interoperability of systems, but also integrated digital systems will as well help us in efficiencies in terms of health worker time, because they will not have to deal with so many things and they can deliver much more. The other key area that the ministry is focusing on is in performance management to ensure that the health workforce delivers what they're expected to deliver, and there is monitoring at all levels of care. So that comes in with the leadership that the ministry is providing to the different levels. We are also strengthening the regional level to be able to provide oversight to the local governments, as well as the local governments to the health facilities and communities. So with this, we will cut off a lot of resources that have been going with frequent movements from the center, but also strengthen the system in terms of resilience to make sure that if there is any, Uganda is prone to outbreaks, any issue, there is leadership and teams at the lower levels that can be able to respond. And then there is this that we are doing, the one you talked about, which also we have done in these 5 days, coming together instead of organizing different conferences. It also will help us to achieve more with the less that is available. Then we are looking at continuing to shape the health agenda as an economic issue. So we will be looking at packaging investment scenarios to interest and attract more domestic resources towards the health sector, plus engaging and retooling of the private sector and promoting manufacturing efforts. Those are the ones I can talk about for now. Thank you.
Okay, thank you so much. So ladies and gentlemen, the ministry is working hard. You've heard about the different things that we are doing to ensure that our systems are resilient. We would also want to learn from other countries. We are not the only ones who are suffering from these shocks. Other low and middle income countries are also trying to make their systems resilient. And so I'd like to invite Christine to share with us how other low and middle income countries are dealing with these shocks, and to share with us what we can learn from these countries about how to sustain health service delivery and outcomes despite these disruptions.
Thank you, Dr. Elizabeth, and good morning, colleagues. Firstly, I would like to thank Prof for the keynote address. I think it gave us a background to what is happening. As you are aware, external health aid is projected to decline by 30 to 40% this year compared to 2023, causing immediate and severe disruptions in low and middle income countries. In March this year, after the US announcement, WHO did conduct a data survey among 108 low and middle income countries and showed that critical services had been affected, especially maternal and child health, vaccinations, emergency preparedness, as well as disease surveillance. And the reduction had been up to 70% in some countries. And over 50% of over 50 countries also reported job loss of health workers. That's straining the health system. And we all know that there was disruptions in terms of training of the health workforce. That's further affecting the fragile system already. Therefore, African countries in the African region need to cushion the immediate impact of these reductions on foreign aid and to adapt a new era of reduced assistance. I think for most of us, we saw it coming, but we didn't know that it was going to come this fast. So now we're in this new era, we should see how to manage given what we have. And there are some few policy recommendations that we need to consider. For example, we need to protect the health budgets that we have and the essential health services that we provide. We need to prioritize health services, especially those accessed by the poor, because those are the ones who are mostly affected. We also need to improve on efficiency through better procurement, reduced overheads, and strategic purchasing. And will not belabor on the issue of primary healthcare and integration, the issue of domestic resource mobilization, as well as stepping into the private sector through public-private partnerships is also important. The issue of health technology assessments, investing in our infrastructure and workforce, and also improved governance. As we speak, only 29% of the African countries have updated national health financing plans, and this needs to be improved. In terms of lessons learned from the African countries, we know that country leadership and global solidarity will be critical for us to be able to move forward. And several countries have already taken decisive actions to strengthen their health systems and protect essential health services. I'll just give you an example, 4 examples of what other countries have done. So for example, Kenya, Nigeria, and South Africa, they've allocated additional health budget, additional funds for the health budget. Some of them have been approved and some are still to be approved, but that was a move that they saw necessary to bridge the gap. Nigeria increased its health budget by 200 million to offset the aid shortfall. And this has been allocated towards immunization, maternal and child health, and as well as other priority programs. We heard Prof talk about Ghana. Ghana has done a lot. It's lifted its cap on excise tax, earmarked for its national health insurance scheme, and this resulted in a 60% budget increase, which translates to about 400 million between when they started up until now. And the country has also gone further. Besides the excise duty, they have launched what they are calling the Accra Reset, which is a board framework to reimagine global governance, financing, and partnerships in health and development, given what is happening and given the fact that we are in a new financial era. And lastly, our very own country, Uganda, has outlined a clear policy agenda for integration of health services and programs, aiming to improve efficiency and sustaining service delivery. And I think we need to applaud our government for that, and we hope this is going to be a case study that will be shared with other countries so that we don't reinvent the wheel. So the funding landscape has changed, and we all know it has changed, and we need to change our mindset. But there are also opportunities that we should explore to make sure that we survive in this environment. The issue of collaborating regionally and sharing innovations, and also issue of food resources, is something that we should take seriously. We have been talking about it, but I think now we need to walk the talk and make sure that it actually happens in real life. We also need to leverage on the African Union and other regional bodies for policy harmonization so that we move together as Africa. And we need to invest in resilience now, not just for emergencies, but for everyday health services. And lastly, as Prof said already, we must remember that Africa bears 26% of the global disease burden, but accounts just 2% of global health expenditure. And it is now time for us to change this trajectory. You and me, we need to act now. And in closing, I just want to emphasize that resilient health systems are not built in crisis. They are built before the crisis. So let's not wait for another crisis for us to build resilient systems. Let's work now together so that we can strengthen Africa's health systems for the future. Thank you.
Okay. Thank you so much, Christine, for that. So resilient health systems are not built in a crisis, they're built before the crisis. And Prof reminded us that we need to get stronger after some of these shocks. Thank you so much for sharing those lessons with us. And you said we need to start now. So in terms of starting now, I want to invite Dr. Edward Bitarakwate to also share with us what are his thoughts on things that we need to do differently as government, as NGOs. How do we move forward given the current situation that we are facing? Dr. Edward, you're welcome.
Yeah, thank you, Professor Elizabeth. As I start, I'd like to thank the conference organizers. This is a really well-arranged conference and a step in the right direction. We're building towards resilience. I'll make my comments, based on 2 decades of trying to support health services in Uganda at the central level, but most importantly at the decentralized level. And I was very happy to see in the audience a lot of the leaders from the local government, LC5 chairpersons, chief administrative officers, our district health officers. And for me, one of the critical elements about discussion is that financial protection, if one looks at the goals of the health system in terms of outcomes, financial protection is a critical outcome. How do we de-risk the population from the catastrophic costs of healthcare in a period where, we're seeing official development assistance reducing? If I borrow from the words of a senior government official, money is coming. But it's not about the quantity of the money. And I agree with Professor Serwada, who talks about how we invest these monies, efficiencies. One critical element we need to adopt, develop, embrace is the multi-sectoral collaboration within government. But in order to do that, we must first change the way we think about the availability of financial resources for healthcare. For example, the ministry, does everyone know that the Ministry of Local Government has performance assessments for health? The 2 minimum conditions, 6 performance measures with about 16 indicators. Dr. Stavia talked about performance management. The local government assesses all these things, but how much are we leveraging those resources that are already with the local government to help us improve the quality of the access to good quality health care? The Ministry of Local Government, earlier in the opening presentation, you heard about efficiencies in procurement, reducing leakage. The Ministry of Local Government has a very active internal audit section. The Internal Auditor General and the teams at the district are able to help us with managing commodities. But do we leverage that? How do we tap into all the different sectors? Yesterday we heard about what the Ministry of Education can do. We want to deepen health promotion. In the 21st century, why do we still have to convince people to sleep under mosquito nets? Or on issues of sanitation? We have millions of children in primary school. Only 40% will move to the secondary level. And that's been like that for a number of years now. How are we optimizing school health to deepen health promotion and the adoption of healthy behaviors so that down the road we are reducing expenditure on treatment? We would like to digitize in order to increase efficiencies in data capture, analytics, and reporting. But we're struggling with internet connectivity. How can we leverage resources within the Ministry of ICT to help with that? Several weeks ago, I was at a regional referral hospital that needs increased bandwidth from UCC, not UCC, from ICT, from NITAU, but they can't afford it. Can we negotiate for subsidized internet data fees? We have several thousand computers in health facilities as we move towards digitization, but they're not enough. Where else can we look to see how they can contribute to our aspirations. Our colleague from the Ministry of Finance isn't here yet, but we know that on the side of HIV, there's a 0.1% of sector budgets. All MDAs are supposed to set that aside to help with HIV and TB programming. But are we programming that money efficiently to help with prevention? Last week, I was in one of the peripheral districts with the fisheries team. We're looking at fisher folk and the risk of HIV transmission in those communities. And we had a deep discussion about the 0.1%. As I think the cow was here, I also saw the DHO. So in short, there's a lot of available financing within government that, if leveraged, will help us bridge some of those gaps and start leading us towards resilience. But we need to change the way we think about the availability of money and how to use it. Very importantly, we need to become a proud nation, a nation that strives to look after its people. We need to assume that no more money is going to come to us. And we need to look at how can we efficiently use what we have. But if we are to get an opportunity for additional funding, I don't think it should be used to meet operational gaps in consumption, but rather we need to use it to make catalytic investments, because those catalytic investments that are going to build a resilient health system. And I say this because, again, every time I'm engaging with colleagues in the field, everyone thinks there's going to be another savior coming. Oh, we hear money is going to come. We hear the situation will stabilize and we'll get additional funding. Ladies and gentlemen, no one is coming to save us. We need to save ourselves. And I think that should be the first drive that all of us need to embrace, so that any help that comes is invested wisely and is catalytic. One of the things I'd like to speak to is the role of NGOs, international NGOs in this. Again, I think international NGOs need to pivot, slowly wean the health system off the dependency, if I may use those words, move away from direct service delivery and pivot more towards technical assistance, and allow the health system to carry this burden on its own, because I think that's going to be key to developing resilience. In the last several months, we saw how we had some lapses in healthcare, some lapses in health information systems, because the shock was abrupt and quite profound, but the system wasn't ready to take on those responsibilities, probably because it had been helped for a very long time. So how do we wean the health system off that direct support for critical service delivery functions? I'd really like us to continue advocating for increased domestic financing through national health insurance. We've all seen the reports that show that out-of-pocket expenditure is quite high with the private sector. How do we have a well-regulated and responsive private sector? But then how do we build a good national health insurance where everyone contributes a little and improves access to good quality health care and saves the communities from the catastrophic costs that they so often incur as they run to the private sector to seek services that may not be available in the public. So I'll keep my comments at that for now, but most importantly, we need to change the way we think about how to finance our healthcare by looking internally, seeking efficiencies, and using any official development assistance to catalyze health system investments that will make us resilient. Thank you.
Okay. So thank you so much, Dr. Edward, for reminding us that no one is coming to save us. We have to save ourselves. And so we need to change the way we think. We need to change the way we invest the money that we have. We need to leverage resources that are available from other sectors. And these are things that have already started happening. We are not completely asleep. There are areas where we seem to be asleep, but there are areas where we are wide awake. And the Uganda AIDS Commission has already started working on this issue. And I want to invite Dr. Nelson to share with us how the Uganda AIDS Commission is working with other partners to see how we can sustain the gains that we have made with regard to HIV/AIDS, how we can provide these services from a more multi-sectoral perspective, how we can strengthen accountability and governance to ensure that we have all hands on deck and all of us are working to get the services that we need available to those who need them most. Dr. Nelson, you're welcome. If you could take 5 minutes, please. We need to also hear from the audience here, and we need to manage our time. Thank you.
Thank you, Professor Krapa. Yes, so, excuse me, I'll speak from the perspective of HIV, and like Professor has mentioned, even before the recent America First policy shifts came into place, as a country we had already, started having discussions for over a year now, and the discussions about how do we transition from where we are now, our current state, to a more sustainable country-led model, and looking at this for over the next 10 years and beyond, so that we can safeguard some of the gains that we've made over the last 3 or 4 decades and build upon those. And we've already heard about what the Ministry of Health is doing in terms of integration. So the sustainability roadmap or framework builds on that. And we've approached this in a collaborative manner, very high level. We have a high level joint steering committee that is chaired by the Minister for Presidency, where we report on a quarterly basis. And ultimately, once we've reached a stage where we are now, the next steps to ensure that this roadmap is presented to Cabinet and ultimately Parliament and adopted before implementation. But I'll focus myself mainly to governance, leadership, and accountability. It has several other components within the framework. It has a financing model, programmatic model, service delivery, community systems, and others. But for now, in the few remaining minutes, I'll focus on governance. So first of all, leadership and governance is a critical foundation for having a sustainable and effective health and HIV response. And I think for Uganda, we have examples. We know how we've managed, the HIV response in the past, how we've managed epidemics like Ebola, Marburg, COVID most recently. We've had leadership at the core of that. What probably misses is the consistency and retaining it at that high level. First of all, from the positioning perspective, the health sector or the health objectives and goals are well embedded in Uganda's development agenda. If you look at the Vision 2040, where Uganda aims to have a modern, state, industrialized country, the National Development Plan 4. The objectives are very well articulated in there. So, and then we've transitioned from a sector-wide planning approach to program-based, and health and HIV belongs to the Human Capital Development Program, where education is the leader. So what do we need to do? The proposal in the sustainability roadmap or framework is that leadership and the governance needs to be strengthened at national and subnational level. And we need to do advocacy for high-level political commitment and visibility, and then enhance accountability. And in what ways can we strengthen leadership at those different levels? One is to ensure that their proposed joint interventions, some of them are occurring now, but they require strengthening. For example, ensuring that we have the regular annual joint program planning, which are inclusive. They should include government, they should include partners and civil society and all the communities. And then we should have regular quarterly program reviews. And I've had, you've had discussions around data. We should generate data and use it for advocacy. I know the health sector, for instance, has annual health sector performance reports. On the HIV side now, we are generating district HIV estimates every year. We know HIV prevalence by district, we know ART coverage, but how are we using this data? It's of a lot of interest, but we should go beyond just, sharing it at national level. Let's make sure that we use this to present to cabinet, we present it to parliament, we present it, to the fora at the district and sub-county levels, but also hold the different leaders accountable. If District X, had, let's say 500 babies born with HIV, let's ask the leaders, what happened to these women? Did they have the tests done? Did they attend the services that they were supposed to have? Did they have the information? And if that is done, then we could be able to get focus on the things that are supposed to be done. And in terms of monitoring and accountability of the roadmap, this also requires to be institutionalized. We've spoken about domestic financing versus the donor financing proportions. We've proposed to Ministry of Finance, as other speakers have spoken, that government needs to take on the most critical interventions within the health sector, including HIV. So the first step, and Professor asked this in the keynote address, is to increase government financing. The proposal is that by 2030, let's have that shift, because he was talking about 95% of the financing the heavy lifting being done by donors. We are saying at least by 2030, let's have more than half of the requirements of health and HIV being financed domestically, and then the donors, we may still need them for a while, but they should finance catalytic activities, innovations that will support system resilience, and not the routine service delivery. Service delivery, the workforce, the recurrent inputs should be financed by our governments. I think for now, I'll just pause there, and if there is additional time, then we could add on some thoughts. Thank you.
Okay, thank you. So thank you so much, Dr. Nelson, for emphasizing those points. I'll now move to Dr. Emmanuel, who is located where the rubber hits the road. In the districts, we need to ensure that community voices are heard. We need to ensure that the local governments are on board. How can we do this? We are all talking about efficiency. Service delivery happens at that level. What are those issues? If you could spend 4 or 5 minutes.
Thank you very much, Moderator Dr. Elizabeth. And I also appreciate the presentations by the other panelists here. Regions are implementers of government's policy, especially in our case, the Minister of Health. And in the whole organizational hierarchy, at the bottom, at the grassroots level, we have the CHUs, we have the village health committees and teams, and the other health centers up the national referral systems we have. Now, the voices of the communities can be heard, first of all, through some of the innovations which have put in place, which include barazas. We've talked about the barazas already, where the institutions, the local governments, especially the health facilities, go out and in an open discussion with the community members and other stakeholders and listen to them, their concerns, their appreciation and complaints. And we get all these into record and use this for planning. And the participative planning approach has to be used in this case, where the ideas which have been picked from the communities are put into our work plans and budgets, which we eventually implement and also forward to the Ministry of Finance and local governments and public service for support for their implementation. And the other way of hearing the local governments and community voices is through client satisfaction surveys. The Minister of Health has already been able to put in place a mechanism which is scan code guided, and even also we still have some paper survey systems in place where we ask the clients, the patients, what they think about our service and where we could improve. And these, when they are put into, they are followed through, we have had efficiencies happening and improving in our setup. We also have a situation where we able to give feedback to the communities what exactly we are doing, so they are able to give trust, to develop trust among us the services which we have. Many people tend to complain because they don't know what exactly is taking place in these hospitals and other health facilities. So in our set, it will be good that we normally give feedback to these communities. The other one, which is I think important for us in a way of improving, is to always hear the alerts they give us through the emergency operating centers we have. These alerts for any suspicious causes of death have to be followed through and investigated and communicated to other various organs in the country to effect and to have a very good effective response to these kind of concerns, especially if they have epidemic potential. We have regional referral mechanisms, which normally we have to use, where we are bringing together a cluster of districts and we work with them to address matters concerning the districts in the health sector. We can also look at areas where we think of efficiencies. Let me talk about this as well. We have been known to be not efficient as institutions, as local governments, and there have been a lot of cry from other stakeholders. But if we did integration of cost centers in our facilities, in our districts, we'll be able to minimize some of these costs and bring about efficiency. If we did the work indicators of staffing needs, we'll be able to know exactly how many staff we need for certain workloads which are being experienced in these facilities. We can also look at, of course, get advice on this for recruitment and deployment as appropriate. But above all else, we brought about performance management of our health workers. A clear-cut efficiency could be experienced in our setup. We, and with the Ministry of Health, have been able to come up with the leadership and governance mechanisms under the integrated care systems, under the regional referral mechanisms, and we are honing on data collections, the analytics and usage to inform performance and general monitoring and even decisions in the health sector. We are looking at scenarios where we have to look at the preventative aspect. So that we talk to people mainly through radio talk shows. We can also have key messages being read over the radios as a preventative approach, so that we're able to curb disease and don't wait for people to fall sick and then they come to hospitals. Lastly, we could also do efficiency studies and audits, which I think are very, very useful. This one is not to purge health workers, but to bring to their attention areas where there's a lot of waste, which can be curbed within the limited resources which we have. Thank you very much.
Thank you. Thank you so much, Mr. Edward. We were told the money is coming. If the money has come, I want to ensure that we know how that money is going to come. So, Mr. Johnson, if you happen to arrive while we were talking, your seat is still waiting for you. Please do come. We'll give you 2 minutes to tell us the options we are looking at. I'm going to request for just 4 questions from the audience so that we can be able to catch up. We can take 2 questions from this side and 2 questions from the other side. We have some mics that should be moving around. Please make your question precise. Make your questions precise. Yes, let's start with Professor Moses. Also indicate whom you're directing the question to. So please be precise, just ask 1 question. If there is another mic on the other side, we can start with that while we make sure that resilience has caught up with the one on this side. Okay, there was... Okay, we can start with the hand just at the back there. There's a hand at the back. We can start with that one.
Thank you, Prof. Elizabeth. I'd like to appreciate the submission made by all the presenters on the panel. 2 things. Permit me, Prof, to submit like I lived at the turn of the 19th century so that we get out of this quagmire of being resilient. 1, we need to, as we think of domestic funding, let's think of domestic rethinking and go back to the roots. I last start off in 1935 when the Public Health Ordinance was invoked. Some of these things that cost us a lot of monies were not there. For example, cholera, which costs a lot of money. I'm sure Professor Serwada knows that when he was in the medical school, there was only 1 bed of cholera, demonstration bed in Mulago. But right now there are beds everywhere in the country. And these are things that come as a result of failure to invoke the Public Health Act. Look at malaria. All these things you see, they are preventable. Look at the border accidents, the road traffic accidents.
Please do ask the question.
Yes. So,
we appreciate the reflections, but please do ask the question.
Much obliged, Prof. The point I'm trying to drive home is that let's invoke the Public Health Act. It will help us in trying to make a lot of saving before we even think of domestic funding. So let's invoke the Public Health Act. It will get us out of this quagmire of looking for monies where diseases are more preventable than treated. I submit.
Okay, thank you. So there's another hand just at the top here, and then we'll go to Professor. Please keep your hands up.
Thank you very much. I'm Mboga Issa, Chief Administrative Officer of Amidst Local Government. We thank you very much for the presentations you have made. The issue of increasing the budgeting, the funding for the health sector, the burden, I'm of the view that those who can afford, I think it is time now to have the health insurance for public officers and those people who have an income. The public officers should be compulsory. We contribute to our health issues such that the government, much as it can complement our issues, it can work on those people whom we are trying to pull under the PDM, those 39%, whom we can pull up. Then 2, I'm very grateful to Minister of Health because now they are key performance indicators and there are issues which you have put like the result-based financing, whereby it looks at how are the performance indicators and the funding reflects. We are very great. Disintegration has moved forward, even under value for money. The Office of the Auditor General has several times put key systematic areas under the health, like now the supplies, the drugs and what. And right now, the result of that has come the recommendation of the last mile delivery. We are very grateful to national medical stores. Now, for me in the islands, in the Buvuma Islands, national medical stores make sure that the supplies are delivered. Even in deep, we have our last health center and Kata Health Center. With those waters border with Tanzania. The drugs are delivered safely. And with the key issues, which looks at value for money and all of the drug intact. I remember when I compared this in 2008-11, I was the chief administrative officer in Yumbe district.
Thank you.
I had a challenge of Midigo. There was a Midigo Health Center in Midigo, where the day we could put the drugs there, the next day they are not there because the stockouts could come because we had refugees, a lot of refugees from South Sudan. And we are very grateful that now you give the medicine based on the what? On the, my chairman of Yumbe is here, and I think now the things have now improved. We are very grateful for that, and we feel that the integration, that is why the assessment under the OPM, the local government, we are looking at issues due to attendance, and health workers having practicing license, and the health management committees there, the deliveries and other issues. So this is an issue. We are not looking at health as a health issue, but health as a comprehensive aspect, as the human capital management system. Thank you very much.
Okay, thank you. Thank you so much. I have the unenviable job of trying to make sure that you're precise. So if you're giving a comment, just make it clear that it's a comment. If you're asking a question, please do be precise so that we can take as many questions as possible. So there are 4 hands on this side. So we'll take those 4 hands, just keep those hands up. And if there are any, there are 2 hands on this side. So we'll just take that round of questions.
So my comment is to Professor Serwada, just to get his reflection on this. Uganda is one of the countries with the highest fertility rate. Each woman has over 5 kids. You know, in my opinion, all systems are overwhelmed, including health. I mean, whatever you do, you know, it's too many people. I mean, 45 million from 10 million in the 60s, is that right? It's just the population growth is just too high. And I don't know in the long term, what you think as a public health professor, whether this is not going to be one of the biggest public health problems. I mean, we can't sustain even our health system with this kind of population growth.
Okay, thank you.
I think I'm next. My question is for Professor Sarada and Dr. Christine. Around resilience health systems, and you both mentioned about the private sector, and I think the private sector is resilient and also it's not being affected by the changes in donor finances, and they really mobilize significant amount of resources around human resource equipment, technology, finance. So moving forward, how can we differently and strategically engage the private sector to be part of, you know, the health system and to meet the needs and challenges of the time?
Okay, good morning, everyone. Good morning, everyone. Let me stand. I observe the protocol and I would like to thank the presenters. My name is Dr. Rena Nigawa. I work for the IRC, Yumbe, and in the refugee settlement. My question is very specific in terms of the refugees. We hope that from these discussions of the weaning off, we've been greatly affected with the donor funding. My question is specific on multi-sectoral approach. We've had a system whereby these refugees are given food by the World Food Program and all that, and we've had a cut in the funding, and of course it has not been sustainable. So looking at livelihood as a social determinant of health, are there plans of multi-sectoral engagement of the maybe Minister of Labor, maybe Social Development, in ensuring that instead of giving these refugees food, we are able to teach them how to be self-reliant, farming, and then maybe sources of income? Thank you so much.
Okay, thank you. So we'll take a question from Dr. Gua today and a question at the top here, then we'll move to this side.
Yes, thank you very much. David Gwatuda from the School of Public Health. I think my question goes to everyone. There are things that I think we fear to talk about, and until we face them, we are going to, I think, continue questioning ourselves, how are we going to solve these problems? So the first one is what Professor Kamia has just mentioned, the high fertility rate in this country, which we cannot sustain. And I don't know what we are doing about it. I think we still have a population secretariat. I don't know what they are doing to curb this. But we always fear to talk about the high fertility rate we have in this country. Then number two is the corruption that is draining the resources we have that would help solve some of these problems we are talking about. There's a lot of money that is going into other areas through corrupt tendencies. And personally, I believe we have enough to finance healthcare in this country and probably other areas. But I think corruption is draining a lot of our resources that would be available to solve some of these problems. Some of the money that is needed is actually much more than what you hear is being drained through corruption. And we need to face it up. Otherwise, we are not going to solve our problems. Thank you.
Thank you very much, Madam Moderator and the presenters. I just have two comments. One is around the community health insurance schemes and cooperatives. I think they are what most people are now looking at. How do we ensure they are regulated, but also that they don't land into the whims of exploiters, because it is the something that is coming, it's the magic that is coming that we need to garner around. The second one is around how do we use the redress systems in the facilities. As a recipient of care, I'm Flavia Chomkama from the National Forum of People Living with HIV. We do have representatives on the HUMICs, but we don't know them. They don't consult us. They don't give us feedback. How do we interrogate this kind of structure, especially for those of us who don't know how to write on those papers, or even who don't know how to use smartphones to use those satisfaction surveys? And finally, I would like to appreciate the ongoing HIV sustainability roadmap development, that they have really considered community system strengthening as one of the integral parts that need to be financed to ensure that we sustain the disease prevention, but particularly HIV prevention, and sustaining the progress. Thank you.
Okay, thank you. So let's move to this side.
Thank you. My name is Gloria Ndekezi Chimpaye, and I'm the head of rehabilitation services at Kosu Hospital. My question goes to Dr. Stevie about bringing services to the community level, and then to Professor Sewada, who talked about rehabilitation at the primary healthcare level. Primary healthcare services being rehabilitative as much as they are curative. Have we considered bringing on board physiotherapists who are actually the experts of movement and who are the experts on prevention as far as communicable health, non-communicable diseases go. When we hear from some experts, they tell us that sedentariness is becoming even worse than smoking when it comes to prevention of non-communicable diseases. And yet, around this space, I think if I'm not wrong, I might be the only physiotherapist in the room. So have we considered as the Ministry of Health, as educators, bringing on board the physiotherapists who are going to drive this agenda of prevention of non-communicable diseases? Thank you.
Let's have those two hands.
Thank you very much. My name is Edward Basenge from Community Health Department in the Ministry of Health. My question goes to Professor Sirwanda. You talked about private sector, and of course, we are focusing on promoting private sector engagement. What is your guidance and views on supporting local pharmaceutical production and medical supplies in Uganda, now that discussions are underway to start industrializations of medicines and commodities in Uganda?
Okay,
Thank you so much.
So, yes, go ahead, and then the last one here, and that's it for today.
Thank you so much. My name is John Bosco Tambara from the Makerere School of Public Health. I've liked Professor his communication when he said we are shying away from some very pertinent issues. There is one that everyone who was talking about it was just being quiet about it and then continuing. What is the fate of national health insurance? We're talking about resilience, and I think it would be the solution that would be discussing at this panel. But I'm not really hearing anything about what does it take for us to put it on the agenda. I think my question is directed to the Ministry of Health, I think, so that we know what do we need to do in order to put it on the national policy agenda so that we can be able to achieve it. Thank you so much.
Okay. My name is Abel Bizmana. I'm the district chairperson Kisoro, but also a PhD scholar at School of Public Health, Makerere. Yesterday, we were talking about leaving no one behind. And I'm specializing in areas of equity, in access to health care. Would we question ourselves in our health system, who is being left behind? Because we think about everybody. We shall access minimum health care package. We are bringing services closer, but there are people, even if you brought the services to the mouth, they may not consume. For example, the ethnic Batwa minority group in Kigezi, and I'm studying them as a main group that deserves equity in access to care. Do we mind about those pockets of people? Perhaps they could be even our incubation of all those health problems we have. Perhaps that Muto woman is the one contributing to maternal death or infant mortality. And that statistic goes among many statistics, and we lose where it is coming from. So how is ministry really trying to cater for those marginalized communities because of who they are in the social determinants? And there are many, a number of them who have Ik, Benet, Batwa, leave alone other marginalizations we know because of special groups that are in our political systems, like people living with disabilities and other people. These people are Ugandans, they pay tax and they have national IDs, but they don't access care because of who they are. So how are you prepared to take care of them?
Okay, thank you. We are now going to move to get the responses to those questions from the panelists. And you've had the questions. Please respond to the ones that were directed to you. but also respond to any others where you feel you can contribute, and also give us your parting shot as you do that. If you could take just a minute or two doing that. We'll begin with Dr. Edward, and then come across.
Thank you. I'll make a few comments. None was directed at me specifically, but I'll just speak about the fertility rate. If it doesn't reduce, we may double our population by 2050. Uganda has one of the highest dependency ratios in the world. It's over 100%. I don't think that has shifted. More than half the population are fully dependent, their children. We don't have a critical mass to spur economic development. It's a consumptive population. There are too many children to have teachers in this country. Not everyone wants to be a teacher. Not everyone wants to be a health worker. So social services are constrained because of our demographic profile. But Uganda is also a country with deep social, cultural, religious norms around fertility and the mysteries of fertility. But I think it's, and I think we have leaders here. It's a conversation that needs to continue. Can the minority carry the burden of the majority? And how soon shall we have that sweet trajectory in economic growth? There are all these debates about GDP. The GDP is at this point, but most people are poor. How will people be rich when they're dependent? So certain things, will not work out at the pace at which we'd like them to, unless we have these conversations. But that said, I think we have the onus to ensure equity and inclusiveness in the way we design health services. And as we talk health financing, we need to ensure that it is inclusive and and doesn't exclude those on the peripheries of society. But I'm not an expert in determining what the country should do. That's a bigger conversation that I think everyone should be part of. There was a comment about health unit management committees and them not being as functional as they should be. That is really like the board of the health unit. But again, this is a function that we cannot do as a health sector alone. We need to leverage the Ministry of Local Government and its structures to help us improve that. And I think for me, it gives a very good example of why we must have strong partnership with other sector players. I don't know if there's anyone from the health team at the office of the Prime Minister or for Ministry of Local Government headquarters. But I think I want to throw it out there to colleagues at the Ministry of Health that we need to reach out, forge the way we partner with development agencies is a way we need to deeply partner amongst ourselves as governmental sectors in order to deal with these issues of access, quality, equity. Thank you.
Okay, thank you, Dr. Nelson.
I would just like to speak to the question of vulnerable groups that the chairman raised. In our planning and budgeting processes as government, there is very clear guidance. For instance, gender and equity budgeting is a requirement. But what happens in actual practice is the problem, that you'll find the people who are doing these processes are not taking care. So those seated in the positions of quality assurance, like I'm sure the chairperson, no district plan would be implemented without the approval of the council. I would make sure that these vulnerable groups and the procurement guidelines also require that when you're doing procurement, you address the vulnerable groups. So at the local government level or even at national level, we should task that the plans have these things, that if there is a procurement, if you know that there is a disadvantaged group, then questions. So this is still within our power. No one out there is going to solve these problems. The guidelines are there, the procedures have been provided for, but it's the implementation that's not being done. And I'm sure we are in a position, and it's good that it's the chair who raises it. I think he has a lot in his power to address some of these things. Thank you.
Okay, thank you. Dr. Emmanuel?
Thank you very much, Dr. Elizabeth. I wanted mainly just to talk to the issue concerning the physiotherapists. Just to inform you that they're already part of the regional referral hospital organizational structure, and there are positions for them at that level. So that means that you're already part of the whole process of health, the whole continuum of healthcare in the country already. And you can do anything from prevention to full rehabilitation, which you may be involved as you conduct your work. The other one which maybe I may want to talk to briefly is the issue of efficiencies focused towards prevention of diseases in the country, efficiency towards what someone talked to as corruption. And I just want to say, let's just improve on efficiencies across all sectors. I know then we can save money for the health sector. Thank you.
Thank you. Dr. Christine?
Thank you very much. I think there was a question on the private sector, but I'll just briefly talk about it, and I'll let Prof. add on. I think the private sector is a very important partner that we can partner with in health, because they have the resources and they have the capacity. But for them, they are mostly focused on the issue of profits. So when we are dealing with them, we need to make sure that we provide an enabling environment so that we are equal partners when we are dealing with the private sector. Because most times that is what prevents the relationships from going on very well. So we need to make sure that we have enabling policies, we have enabling environment, and we bring them on the table so that they see what we are discussing. I'm not sure today whether we have the private sector with us here, but it will be good that we bring them on all platforms when we are having discussions so that they understand from our perspective and they can appreciate our needs, and then we are able to build a mutually collaborative relationship with them. So the private sector is very important. There are examples here in Uganda of successful private-public partnerships, but I think we need to scale them given the fact that we are in an era where there are less resources from our development partners. So the private sector becomes a very important partner for us to collaborate with. So I think from now onwards, we need to see how we can increase our partnership with the private sector for the benefit of the population. Thank you.
Okay, thank you. Professor Seroda?
Hello, okay. Dr. Moses, when there was a marked reduction in US funding to Africa, the first thought that came to my mind is not HIV. The first thought that came to my mind was reproductive health. You know, for some reasons, historical, much of Africa has been, in terms of reproductive health, has been heavily dependent on USAID funding. Hugely heavy. And reproductive health, which is a wide range, but we shall talk about managing fertility, is one of the most important component of it. So if I talk about how are we going to prioritize our primary health care, I would say reproductive health is going to need a lot of funding. I agree with you is that managing fertility is also one way to manage resilience. It affects a lot of other things that the panelists have talked about. So I think that is something that will really have to, I would put it number one in terms of prioritization, especially when we are reallocating funds in this particular, in Uganda specifically.
So yes, it's a concern. Unfortunately, it cannot be corrected quickly. It will have to have committed funding over a period of time to be able to control fertility rates. I mean, I remember Kenya was at one time, they had the highest fertility rates 10 to 15 years ago in East Africa, but they have been able to manage to do it because of heavy government investments. So I think that is going to be extremely very important. Private sector, I completely agree. We now need to private sector in several ways. I've talked about procurement, I've talked about manufacturing, I've talked about, both local or regional. I think government will have to put into place policies and indeed facilitation of private sector in a very strategic manner. It has to be a very comprehensive strategic plan in manufacturing, so that we can be able to locally or regionally manufacture or create partnerships that can give us the ability to do local manufacturing. It has a spin of availability and also making products much cheaper. But in terms of health service delivery, and this came up when we were having COVID, there were more intensive beds in private sector than they were in public sector. And many of us were very much involved in the management of COVID. The president was saying, why are the private sector charging so much money in intensive care? But government hasn't invested, or the taxes it puts on all the equipment into intensive care. There has to be a more strategic way in how government can help private sector be able to actually provide services at a much more affordable rate. Hopefully, if there's a national health insurance, there would be able to be an interaction between health insurance in the private, services provided by the public sector, so that people in public sector can access them through a health insurance mechanism. But the ability to be able to cooperate between the two sectors, I think, is going to be extremely very important in providing services moving forward. That's an area to explore moving forward. But I think the most low-hanging fruit is really in manufacturing and being able to help into procurement. Somebody asked me a question about physiotherapy, but I'll leave that to Minister of Health. I'll comment on the issue of who is being left behind. Who are the people left behind? I would say the data should tell you who is being left behind. It could be a very different sector of people when you look at HIV. It could be a very different set of people when you look at reproductive health. It could be a very different set of people when you look at non-communicable. But look at your data. The data is telling you who is actually at risk or who is being left behind. So it's a question of looking at your data to be able to define who is actually being left behind. Corruption. We sort of nicely, diplomatically put it into governance, leadership and governance, and accountability. But yes, I agree, Dr. Gua, today that corruption is you'll find that everybody has talked about that if we can optimally use the money we have, we can be able to go a long way in financing our health systems. And corruption is something that probably is eating away to much of. Actually, when you talk to people in the Ministry of Health, for a variety of reasons, they tell you can't finish the budget that we give, the money that we give the Ministry of Health. Can you believe it? And it is to do accountability, proper accountability, not well done accountability. it is to do, and why is not proper accountability, it's a whole reasons. But you could find at the bottom that corruption is part of it. They can't be able to account for money. I know for sure when we were doing a lot of district-led programming, trying to get accountability at the district can be a big challenge of the money you have already dispersed. So I think that is a systematic problem that needs to be addressed out there. So it requires leadership. The accountability will have to come straight from the leadership to demand it and also follow it by example. But that is something that I think needs to be carefully and head-on confronted. Otherwise, it will be just putting money and money just flowing out without doing anything. So I appreciate that, but I think it's a discussion that we need. I think one of the things, though, which I found much more effective in South Africa is advocacy groups that really put a lot of pressure on governments for accountability. Uganda doesn't have strong advocacy groups that demand and actually demand services and demand services. South Africa, during this struggle in providing HIV for its population, it's the advocacy groups that put South African government on their feet to be able to provide those services. So advocacy is going to be extremely very important, and consequences of lack of provision. Thank you very much.
Thank you, thank you. Dr. Tavia, and also respond to the insurance issues. Where are we? How can we better regulate community-based health insurance?
Yeah, thank you. I think Prof has ably talked about most of the things, summarizing the key questions. National Health Insurance Scheme, it is still very high on our agenda, and we are pushing this, and we hope that by next year we will be somewhere. It is something that is dear to us and is going to help us with a lot of issues that we are facing with our health services. Physiotherapists, I think the director has talked about it, but I wanted to emphasize the issue of prevention. We have quite a number of actors in this space, including physiotherapists. And I said we have placed the village health team members at the community level, at the parish. We have the community health extension workers and other structures that are in place to support us in the health prevention agenda, engaging of the different community structures as well that we have in our community. Then the issue of, I know Professor has touched it and he has given the right, you cannot repeat what the professor has said, but I wanted to add something with your permission, being a generalist. You said the use of data. We have an issue with our, and someone who asked said, what is the Minister of Health doing? But where are the people who are being left behind? And who are they? We have to interrogate the data that we get within our local governments for all services, not only health. Because if these people are not on board for other services, then they will end up having health issues and they will come to the health services sick and becoming a burden. They will be the ones having the many children you are talking about. The fertility rate will be higher. In those groups, they are not accessing education and so on. So we need to know who is this that is being left behind across the services that government is providing to the people. And then for those that fall ill, we also need to use that information. Who is getting sick? Is it the children? Is it the elderly? Is it the, and where are they? Which community? And so on. So we need to start using the data to help us to offer the services to reach those people that are not accessing our services, especially prevention services. I think that is what I can add. Okay. Oh, community health insurance scheme, we take note of this. As we pass the National Health Insurance Scheme, I think this is one of the areas that will be reflected upon and how best they fit in. Thank you.
Okay, thank you so much. So, ladies and gentlemen, this morning we set out in this panel to look at health systems resilience and what we can do. And we've talked about the what and the how. We've emphasized issues related to strengthening governance, leadership, and solidarity. We've talked about the fact that we need to use our finances better before we ask for more. And the panel has talked about pooled procurement, local manufacturing, leveraging resources from other sectors, making sure our investments are catalytic, promoting integration, prevention, fertility, corruption. We've also talked about getting more money from the private sector and expanding that. We've talked about using data more and ensuring that whatever we are implementing is evidence-based, doing audits to ensure that we are actually doing this. But we also have emphasized the fact that we still need more money. And so we still need to see the budget increased for health. We need to see the budget increased for different social services. And at the end of it all, we need to ensure that the community is not left behind. What is the data telling us? Who is being left behind? And how can we ensure that their needs are met? So we shall conclude this session on that note. I'd like you to join me in thanking our panelists who have been with us and who have shared so eloquently. Thank you so much, our panelists. I shall now hand over back to the moderator.
Thank you. Members, you can appreciate Dr. Elizabeth. Dr. Elizabeth, you can step back for a group photo with the panel as we send some communication. So the media, Tony and team, come and take a picture of our panel as we guide on what is going to happen next. So I kindly request the IT team to load the guidance. Cameraman, Tony, the cameraman, and the team. They are coming. Tony. Okay. Thank you. As they take the picture, today, this is the only session we have as plenary. The remaining sessions are going to be in terms of the breakout rooms. And we request that we give guidance so that you are able to follow and participate effectively. We shall have 4 rooms that will be hosting these sessions. The first room is Victoria, where we are now. And in the hall where we are, which is Victoria, we shall have 3 sets of discussions. The first one, we are going to look at microbial resistance, and that will take us up to lunchtime. And then after lunch, we shall look at issues of TB and integration in HIV service delivery. So in case you have an oral presentation or you're a panelist in these sessions, this is the hall where you will be, and that is what we shall be doing. And during each break, we can have time to look at the posters and the stalls outside instead of spending so much time in the lines. Then in the other 3 halls are downstairs, where we were yesterday. That is, one of them is Mera Hall. In that one, we shall also have, the presentation again. So in Mera, we shall also have 3 sessions. The first one will look at issues of climate change. You can take a screenshot, issues of climate change. We have a topic on mental health. We recall in our pre-conference, issues of mental health came out strongly. So the team is back together with more panelists to discuss issues of mental health after lunch in Mera Hall. And beyond that, they will also combine it with issues of burnout at workplaces, which will also contribute to mental health. Then in Shina, that is also downstairs, we shall be looking at epidemics and One Health, then immunization, and how to end malaria death. So the presenters, Shina Hall, that is what we shall be looking at. Then the last is Royal. In Royal Hall, we shall look at issues of SRH and also mortality surveillance, and also how to look at being prepared in our systems. So ladies and gentlemen, we request that we follow that guidance, because if we don't, then we shall end up being mixed up. And by now, we hope that each and every one of you registered. We shall also have registration in the breakout rooms. And as you registered, ensure that you picked your coupon for the meals. Ensure you have your coupon and keep it safely, because they will not be giving out any more lunch vouchers. In case you don't have and you registered, confirm with the registration table. As we go, it's time for our break tea. Our break tea again has been separated into 5. So we have 40 stations downstairs. Again, don't overcrowd the entrance here, because they have done it to plan for you well, instead of being at one station when there are not enough facilities. So we have enough tea, 4 stations downstairs, and also a station up here. So for our panel that was here, the keynote speaker, led by the commissioner and the senior leadership of the Ministry of Health, together with the heads of institutions that are here and the directors of the regional referral hospitals, you'll be ushered to your tea by Kato and Ruth. And then the DHOs, the LC5 chairpersons and chief administrative officers, we shall use the first tea point here. The rest of us, MOH staff and the presenters and other delegates, let's go to the lower part. We have 40 sessions there. We see you after lunch or after break tea in the respective 4 rooms that we have said here. And please keep an eye on your variables. Thank you. Let's have tea. The sessions in the breakout rooms will start immediately at 11:50. So all the chairpersons and the presenters proceed to the rooms. Those down, you have tea near them. Proceed and start loading the presentations. Thank you.
God Almighty Father, we want to thank you this morning for bringing us here. We want to thank you for the gift of life.
I'm very delighted this morning that the full conference has started.
This historic conference has been organized by the Ministry of Health together with Makerere University, and it comes at a time when we are facing a double burden of disease, as we had this morning, with our long-standing communicable diseases, yet also seeing an increase in non-communicable diseases.
As civil society organizations, we get the mandate from the communities and we support the communities, and on behalf of these communities, we stand here to reaffirm our commitment to strengthening Uganda's health system by leveraging existing capacities built around communicable and non-communicable diseases to deepen community engagement and improve health outcomes.
It's truly a unified action. It's not just a Ministry of Health conference. It's not just the university conferences that we often have. It is a collection of everybody that we need to make a difference in this space.
Us being here in hundreds here is a testimony of the gains that we have had a system to be able to showcase the gains in science by holding such big meetings.
And therefore, Uganda continues to confront long-standing communicable diseases.
Going forward, we as other universities will continue to be involved in these national meetings actively so that we can also contribute to the discussions.
United, let us build a healthier, more resilient, and prosperous Africa where no one is left behind. I thank you.
And I think that's what has been lacking. The knowledge of non-communicable diseases and communicable diseases is well known by all of us in this room.
It is indeed a great honor and privilege to welcome you to the inaugural National Annual Communicable and Non-Communicable Diseases Conference, held jointly with the 19th Joint Annual Scientific Health Conference 2025. This collaboration between the Ministry of Health and Makerere University School of Public Health demonstrates our shared commitment to advancing health, research, policy, and practice. And allow me also to add my voice to deeply appreciate Makerere University and of course all the other universities present for this collaboration. And also in a special way to thank the Department of Communicable and Non-Communicable Diseases for organizing this conference. We have made progress as a country, commendable progress in the last several years. And as Professor Bruce clearly put it, we are here to protect the gains. And integration is one of the best ways to protect these gains. So if you find yourself here and you're not willing to protect the gains, then you are misplaced. As I open this conference, I appeal to all of us to renew our commitment to prevention, innovation, and partnership. Every policy, every intervention, and every community effort matters. Unified action is urgent if we are to end preventable, communicable, and non-communicable diseases by 2030. It is now my honor and pleasure to declare this conference officially open for God and my country.
without wasting a lot of time, allow me welcome our panelists led by Dr. Stavia.
Allow me to thank the team, Uganda Cares, for creating an open about service delivery integration. The biggest elephant actually is not integration, is lack of awareness about health issues, disease prevention. I think that is the biggest elephant we have in the country.
Like the previous speaker said, you'll find that one person has multiple diseases. It doesn't stop someone from with hypertension from having malaria as well. So with integration of services, it's one of the advantages that we will see, that the patient can get all the services at one point.
I live with HIV since 1994, when I was discovered with TB. 1995, I was one of the guinea pigs for PMTCT when we were just taking as we went into labor, and I'm glad now it has become fully blown into EMTCT, and we are seeing less mother-to-child transmission. I have undergone divorce. I have lost a husband. I have survived cancer. I have been into emotional strain since the stop work order. And I'm still the same person. And I think that is the best description of integration we are talking about. And yet, I continue to survive. And that is the voice of community.
How about we create something I could call a Yuga Aid for the Ugandan people? USAID was from the United States of American people. How about Yuga Aid? And this is something that can be initiated by this scientific community. I understand very many of prominent people are in this room who have the potential to initiate something like this.
I really appreciate the presentation, and I'm really excited about
the whole thing. I think they're saying people from the village, so